Eating disorders also have really serious, dangerous, and sometimes fatal medical consequences.
Welcome to Talking About Kids. I am your host, R. Bradley Snyder, researcher, activist, and author of The 5 Simple Truths of Raising Kids. This is the second of 4 episodes in Talking About Kids' series on eating disorders. In the first installment, the preeminent Bryn Austin addressed the prevalence and stigmas of eating disorders. The core of this episode is on why we care. My guest to help us understand the harm to kids caused by body image issues, unhealthy eating behaviors, and eating disorders is the amazing Jean Doak. Jean is a professor of psychiatry at the University of North Carolina at Chapel Hill and the clinical director in the universally respected Center of Excellence for Eating Disorders. The Center of Excellence for Eating Disorders was founded to help ensure access to appropriate care for everyone. And for over 20 years, it has been doing just that through its 3 pillars of research, training, and service. Talking About Kids is sponsored in part by the Arizona Department of Health Services Must Stop Bullying campaign through its Title V Maternal and Child Health Program. For more information, go to muststopbullying.org. As you can imagine, students, families, colleagues, and patients are constantly vying for Jean Doak's attention. She did not make the time to come on Talking About Kids to meet me. She came on to get the word out about research and resources that benefit kids. You can do your part by sharing this series or this episode with your friends and your professional network. And now, the interview.
Once I was approaching the completion of my internship, as anybody in the field who approaches the completion of their internship, there is an opportunity for further clinical specialization by doing a fellowship. And one of my supervisors had asked me if I was interested in doing a fellowship, and I hadn't really put that much time or thought into it. And as she was talking about it a bit more, we were talking about just my interest with pediatric and adolescent psychology. And a colleague and friend of hers was overseeing a fellowship that specialized in adolescent eating disorders. And she encouraged me to apply. And I was a bit hesitant because I didn't feel like I had the expertise to dive into a fellowship that specialized in eating disorder treatment. So I went ahead and submitted my information. I was lucky enough to get interviewed. And during the interview process, I said as much. I said, this sounds wonderful. This sounds terrific. I would love the opportunity for further specialization in adolescent mental health and specifically with eating disorders, but I just don't have the expertise to bring to the fellowship. And the supervisor or the director of the program, who is an adolescent medicine physician, said, "Do not worry about that at all. We don't expect anybody to come into fellowship with any of this expertise whatsoever. We will train you." And that is the focus of our fellowship, is to train healthcare and mental health professionals in the field of eating disorders, specifically working with children and adolescents and young adults. And I said, wow, that sounds terrific. And so I was fortunate enough to get that position in the fellowship. It was a 2-year fellowship where I was able to specialize in eating disorder treatment. And that essentially launched my career in the field of eating disorders.
Going into your fellowship around eating disorders, did you have any preconceptions about what you were going to be studying and the kind of work that you were going to be doing? And how did your understanding of the issue change after the fellowship started?
That is a great question. I don't know if I had any preconceived notions, so to speak. I mean, during my coursework, I definitely studied eating disorders. I just hadn't done treatment in the field of eating disorders. But I will say during internship, one of the things that was quite striking to me when we would get consulted on a patient who might have an eating disorder is the amount of fear, worry on the part of healthcare providers, feeling unequipped or unsure of what to do. And also accompanied by that, oftentimes patients and or families have a lack of understanding or misperception around what it means to have an eating disorder.
Okay.
And there's accompanying shame and guilt with an eating disorder as well. And so I think it was this kind of bifurcation that really left individuals with an eating disorder um, feeling as if there's a lack of support or treatment
Right.
or even knowledge. And that's no fault of anybody involved in that process. It's just eating disorder treatment is just not a standard treatment intervention in the field of pediatrics or
Right.
pediatric mental health.
Well, and we've been saying eating disorder, so we should probably kind of define
Mm.
what it means for there to be an eating disorder,
Mhm.
and the extent to which a precise definition even matters.
Yes, I will say it does matter, but I'll speak a little bit more broadly because I think oftentimes there are so many misconceptions associated with eating disorders that it'll be
Mm,
important to have a baseline or foundational understanding of what they actually are. And so, eating disorders are a group of psychiatric illnesses. Um, where there are specific definition that fall under specific criteria associated with each of the
okay.
diagnoses. And so one thing that's particularly important for everyone to know is when I say psychiatric illness, it is the same type of broad category as depression,
Okay.
anxiety, ADHD, et cetera. These are all psychiatric illnesses. And oftentimes, like with depression and anxiety, there are more specific definitions or diagnoses within these broad categories. So, if helpful, I can just kind of provide a very brief
Yeah,
overview of
please.
some of these diagnoses. Okay. So, probably one of the ones that people have heard of most often would be anorexia nervosa. And I'll say, instead of going through the criteria, maybe I'll just provide like a defining feature with each of
Yeah.
the diagnoses. Well, with anorexia nervosa, the defining feature would be an intense fear of gaining weight and restriction of energy intake meaning food.
Right.
And then it's also associated with significantly low body weight relative to age, sex,
Mm,
developmental trajectory of their physical health, and then also a disturbance in the way that they experience their body weight, size, and shape. Oftentimes, that can be referred to as body image disturbance.
okay.
And so that is the defining feature of anorexia nervosa.
Nervosa.
And again,
Okay.
like I said, there are different subcategories. I do want to add that when we talk about low body weight, there's low body weight relative to like an estimated body weight. And then
Okay.
there's a low body weight based on having lost a significant amount of weight, even though on paper their weight may not necessarily be considered low, if that makes
Mm,
sense. But functionally, anorexia nervosa and the defining features are the same, independent of that absolute weight number.
Okay.
So that's anorexia nervosa. Bulimia nervosa has a defining feature of binge eating. And I'm going to maybe pause and define binge eating if that's okay, because there is a
Yeah,
specific
please.
definition for that. So, binge eating is eating an unusually large amount of food in a discrete period of time while experiencing a sense of loss of control over what or how much is eaten.
Hmm.
And it's often accompanied by marked distress or feelings of guilt or shame. So that's binge eating. The other component of bulimia nervosa is the use of compensatory behavior to prevent weight gain. And I'll define what that is if that's okay.
Yeah.
So the use of compensatory behavior would be behaviors such as self-induced vomiting, misuse of laxatives or diuretics or other weight loss type medications,
Right.
fasting, or even excessive exercise. That would be kind of the categories of
Okay.
compensatory behaviors to prevent weight gain. And then also with bulimia nervosa, a defining feature is self-evaluation, which is unduly influenced by body size, weight, and shape. So
Okay.
there's that body image disturbance that's
Right.
presenting itself again. Another diagnostic category is binge eating disorder. So remember, I just described binge eating, or I defined it earlier with
Right.
bulimia nervosa. What's different between binge eating disorder and bulimia nervosa is with binge eating disorder, it's defined by having episodes of binge eating without the compensatory behaviors to prevent weight gain.
Hmm.
So
Okay.
that's how one can differentiate bulimia nervosa from binge eating disorder. And then another common category, particularly, I was going to say particularly with pediatric patients, but that's not the case. This could be applicable to
Okay.
any age. ARFID is avoidant restrictive intake food disorder. And so the defining category or features with this would be avoidance or restriction of food intake, persistent failure to meet appropriate nutrition or energy needs through
Hmm.
oral intake or food, significant weight loss or significant nutritional deficiency, and then also a reliance at times on oral or nutritional supplements. And there is an interference with overall psychosocial functioning. With ARFID, there are three broad categories, and I think it's helpful, although all the other diagnoses I've mentioned, or some of them may have different categories or subtypes.
Okay.
With ARFID, it's particularly important to talk about the three different subtypes. One is a lack of interest in food. So
Hmm.
someone can develop ARFID just by having complete disinterest in food. Nothing particularly sounds appetizing. They may or may not have hunger cues. If they do, they don't necessarily act on them. There's a disinterest in shopping for food items, cooking,
Right.
etc. So just an overall lack of interest in food. The second subtype would be an avoidance of food due to sensory issues. So either taste, smell, texture, color. So we see that often with younger children, and there is an overlap with some co-occurring
Right.
disorders like autism, which is probably the most common one with this ARFID
Exactly.
category. And then the third subtype is an avoidance of food due to an aversive experience. And the two most common aversive experience would be like a choking episode. Kids all the time end up choking on food, and
Right.
sometimes then that gets equated with a specific food type or specific food. And then the way it becomes a disorder is that that food type gets more generalized, and the food categories that they'll eat becomes more and more restrictive or more and more narrow. And then another aversive consequence or experience would be an allergic reaction, like a severe allergic
Right.
reaction.
One of the reasons I asked the extent to which it matters
Mm.
is as you're listing those definitions and the kind of the defining characteristics of each of those disorders, I can't help but think about influencers, people at
Mm.
my gym, some of my friends that have some of those characteristics. I mean, it seems like, we have drugs that specifically make you averse to food.
Mhm.
We have, people who will are selling online right now techniques, so that you can, avoid eating, so that you can. So, what are there bright lines about when merely maintaining your weight becomes a disorder?
Yeah, one of the things, kind of a guidepost or a guiding principle that we often use, especially with children and adolescents, is that unless there's a medical reason or a
Right.
specific diagnosis that would warrant weight loss or a narrowing of food choices, we really don't encourage any of that, especially with children and adolescents. Their bodies are growing and changing and developing
Mm,
at such a fast rate that we really don't know where their body size, weight, and shape is going to end up. We just don't.
okay.
And in that regard, we want to discourage any kind of dieting behaviors or excessive exercise. In that regard, we really want to promote that all foods are healthy foods, everything can be eaten in moderation, and that exercise is great for mental health benefits as well as
Okay.
cardiovascular benefits. And if we can decrease the focus on exercise for influencing body size, weight, and shape, that will allow exercise to be incorporated into kind of an overall lifestyle perspective rather than a have to or I must or a
Right.
form of punishment in that regard.
Thank you for bringing it back to kids, because I do want to know, given how much our society seems to be, obsessed with health, we're getting some very strange messages right
Mm.
now in the media, right? We get messages that we absolutely can't body shame somebody, and we shouldn't. And so, but I also know that I have parents and I have teachers and I have people who are working with kids in their program that have kids that they want to be healthier.
Mhm.
So, but we don't want to body shame, and
Mhm.
that's absolutely true. And then we also have a whole segment of media that's telling us that there's no such thing as too skinny,
Mm.
right?
Mhm. Mhm.
And it's showing, and it's constantly giving us new ways to work out in between workouts and to cut calories between cutting calories. But why do we care if our kids are, like, obsessed about their bodies? What's the real danger of having kids develop eating disorders?
Well, this is a very complex question that you're asking,
Mm,
because, you know, um, uh, in our culture, which is, it's not necessarily unique to the US, but probably more prevalent in Western cultures, there is an overemphasis on diet mentality. And there is, unfortunately, significant stigma associated with higher than average weight or being
mhm,
in larger bodies. But earlier I was mentioning that eating disorders are psychiatric illnesses. What I didn't mention at that time is that eating disorders also have really serious, dangerous, and sometimes fatal medical consequences.
okay.
And so when individuals engage in restrictive eating behaviors or patterns and or excessive exercise and or attempts at significant weight loss, it compromises our physical health. And so that physical health has consequences in all sorts of categories: cardiac, heart failure, electrolyte
Mm,
imbalances, gastrointestinal issues, and what we also know as well is that these behaviors can impact our thinking and the way our brain functions. Even the size of our brains can actually shrink with excessive weight loss. So there are cognitive impairments that can happen. Mood and anxiety or other types of psychiatric disorders can then present themselves. There's bone loss that can occur, and then also significant hormonal depletion with males and females. So estrogen and testosterone alike. So these are significant medical consequences, and it's unclear whether or not any of these areas of medical functioning can actually be restored for everybody once they are recovered from an eating disorder. So it's important for everybody to be aware of the dangers associated with eating disorders, that it's not just about weight loss. It's not vanity at all that's driving it, but they have some significant medical consequences that oftentimes may not be reversible.
So now I'm terrified. And I'm
so
terrified,
sorry.
Jean. Yeah, no, well, and here's why. Because if you have an adolescent who is anxious, if you have an adolescent that struggles with regulation, for example, one of the things that you'll often prescribe them is exercise.
Mhm.
Being able to go out, expend energy that way, both sports but individual exercise. Those are things that can help you with anxiety. They've been shown to help with depression. They've been shown to help with a host of mental health issues. And what you just told me is that this adaptive behavior can become maladaptive when it starts to actually create the very problems that we're looking to address with the exercising, with the changing eating habits.
Mhm.
And then you mentioned that if it goes too far and becomes maladaptive, we may do permanent damage.
Mhm.
Okay.
Yes. So
So if other people are terrified like me, what do we look for? What do we watch for
yeah.
so that we know that, boy, this is really great that I've got this kid in my program or a kid in my class or even a kid in my home that has taken an increased interest in their health, and I start to see benefits. Maybe they're less anxious, maybe they're less depressed, maybe um, when do I start worrying that they're doing it too much?
Mm. You mentioned something a couple of times that I think will be an important differentiation for us to talk about, and it's this
Okay.
idea of adaptive behavior,
Right.
and this continuum of at what point does adaptive behavior become maladaptive
Right.
behavior. So I think about, you're right. It is not uncommon for us to talk about the mental health benefits associated with exercise. I think that's wonderful. And I think if that is the driving force, then absolutely we would want to encourage it. We would want to reinforce it. We would want to provide as many opportunities as possible for that. And as with a lot of behaviors, they exist on a continuum. And
Right.
so the things to look out for would be when exercise starts to become excessive.
Yeah.
So, to what degree does it start interfering with day to day activities? To what degree does it become a priority over everything else? To what degree will somebody engage in exercise at the cost of other things in their lives, or
Right.
even like an inflexible approach to exercise? So, like continuing to exercise outside despite really bad weather, or
Mm.
continuing to exercise while injured, or those are the things that those would be signs or signals that maybe it's seeped over into the maladaptive part of the continuum. So, with most adaptive behaviors, we also want to incorporate flexibility.
Right.
So, as much as we want to encourage maybe going outside several times a day, if the weather's really crummy, it's okay in any given week if maybe that only happens one time.
Right.
Truly okay, because there will probably be other weeks in the month where it'll be really nice outside. So, that flexibility, I think, demonstrates some um, cognitive opportunities for children and
Mm.
adolescents and even adults to incorporate. Again, it's moving away from things having to be all good or all bad, or musts or shoulds. And instead, it's more of a nice to do type of activity or helpful activity.
Is there, when I think about other maladaptive behaviors in children and adolescents in particular, I guess, the one of the things that I've noticed is that if a maladaptive behavior, the maladaptive behavior, the individual talks about a weakness in themselves.
Mm,
So if it's a maladaptive behavior and it's missed or it's changed or it's an unhealthy habit and it's missed, the individual will talk about how there's a problem with them, that they missed,
mm.
that they overate, that there's something wrong with me, that I missed this exercise, that I is it, does this exist too with eating disorders?
Absolutely. I mentioned guilt and shame earlier.
Yeah.
I think there are a lot of those types of feelings that get intertwined with some of the eating disorder behavior. So, whether it's guilt or shame about eating more than what an individual wanted, or guilt
Right.
or shame about an inability to restrict as much as they wanted, and
Right.
how those could get tied in with issues of self worth. And so it's one of the things that we work on in treatment along the way. But I do want to maybe target these feelings from a description of how an eating disorder functions, like how does it come to be.
Okay.
So what we do know about eating disorders is that they are biopsychosocial diseases. So, bio describes the genetic makeup or the
Mm-hmm.
genetics that may lead someone to have a higher propensity to developing an eating disorder, and also some personality constructs that's related to the psychological piece. There are some psychological reinforcers that can
Mm.
get laid down with some individuals that may make them more prone to have an eating disorder. And then the social piece, which is what we've been talking a lot about, would be our culture
Mm-hmm.
and the influences of our culture. And so those are the components that make up or lead to the development of an eating disorder. But I will say, from a genetic piece, and we can think about like any other psychiatric diagnosis, whether it's depression, anxiety, ADHD, etc. There's often a genetic
Mm.
factor in the family history. It may not be exactly that disorder, although that's probably the highest correlation of having an immediate family member with an eating disorder and having a child with an eating disorder. But it could be any other mental health illness that can increase that genetic load.
Okay.
The other thing that we also know, and consistent with other disorders as well, is that just because there may be a psychiatric illness in, like, say, the immediate family, doesn't mean that the
Right.
child will have a psychiatric illness, right? Like,
Right.
we look at sibling and twin studies, and, one child may be affected, whereas, like, the other three children in the home are not. And so we do know that just because a parent may have a psychiatric illness doesn't mean that every child will have a psychiatric illness as well. But the biopsychosocial model around eating disorders is particularly important in
Yeah.
the way we think about interventions and the way we think about prevention as well.
So, and my assumption then is that an intervention has to address all three. Is that
Yes,
correct?
yes,
Absolutely.
yes.
S- I wanted to get your advice, and I know that, the National Center of Excellence for Eating Disorders, your center, does a lot of work around this. But so I want to get your advice for parents,
Mm,
for teachers, for direct service providers who suspect the kid in their lives
mm,
needs that additional intervention. And I want to start with, your center put on a interesting flyer around or tip sheet about the language to use around these eating disorders. And
Mm-hmm.
can you talk to me about that and why this language is so important?
We always encourage to avoid comments about body size, weight, and shape, positive or negative.
Mm,
Because what we do know from research is that most appearance based comments can be harmful. Children, adolescents, and frankly, adults can glom onto comments and really interpret them in ways that could be really harmful.
right.
So instead, we would encourage focusing on what individuals actually have control over. For kids and adolescents, it could be their haircut or their hairstyle, or what color they have in their hair, or their clothes, or their interests, music, movies, sports. All those kinds of things are things that they have complete onus and control over. They may not have onus or control over their body size, weight, and shape.
Yeah.
And so we would want to avoid comments around that because they just have no control. And sometimes when comments are made around those things, there's an implication that maybe they should have better
Right.
control. I just use air quotes, but I'm realizing I'm not on video, but better control over their body size, weight, and shape. So that would be what we would want everyone to avoid and what we would encourage instead. Um, Also, we'd want to avoid any negative self-talk or criticism about body size, weight, and shape. It is, again, in our society and in the context of a diet culture, it's almost promoted. It's often joked about.
Mm,
People will refer to themselves or their bodies in really derogatory terms.
right.
And and as we all know, children and adolescents listen and hear everything. We may not think that they actually listen to us as parents, but they really do pick up
Right.
on this type of talk. And so instead, we would want to model body positivity. And as we were talking about earlier, exercise for mental health benefits versus
Mm,
exercise for weight loss, or exercise for punishment for having eaten a certain amount of food or a type of food. And we really want to disentangle this idea that value and worth are dependent upon body size, weight, and
yeah.
shape. Some other things, I think one other thing, because we've been talking about diet culture, and this is important because this goes to modeling and this goes to what we teach our children and adolescents. We really want to avoid dieting or restrictive eating. Again, the
Mm.
caveat would be unless there's a medical disease based
Right.
reason for that, we want to avoid it completely. There's no reason for children and adolescents to be engaging in dieting or restrictive eating behaviors. And we want to avoid categorizing foods into good food or bad food. That just
Mm,
sets everyone up to think, okay, well, bad foods are this. Therefore, if I eat this, I am bad as well. And so
right.
we want to avoid that as possible. We want to avoid this idea of being deserving or not deserving of certain foods because food has no moral value whatsoever.
Mm,
So again, this is really hard for us. Like if we really think about it, we will be surprised at how much this language casually infiltrates our day to day experiences.
right.
So, we want to model a very broad spectrum of eating a wide variety of foods where the focus is around balance and nothing is off limits whatsoever.
Correct me if I'm wrong here, but I think that the center also wants to make sure that if you know that there is a kid in your classroom or in your program um, that has a disorder,
Mhm,
that you're careful with even how you refer to that disorder.
mhm,
Correct? Like
mhm.
this is a larger shift, and hopefully, if you've been listening to talking about kids for a while, you know that we're encouraging this across the board. That you never talk about somebody as having as being defined by this disorder,
Yes,
right?
yes.
Help me with that, Jean.
Yes. So I think, for parents and educators and, anyone who's interacting with kids, I do want to emphasize that eating disorders can present in anyone, regardless of gender, age, race, ethnicity, culture, size, socioeconomic status, or sexual orientation.
Mm.
So there is this heightened sense that that could be anyone in the classroom, anyone on the soccer field, anyone that they may have interactions with. And it's always person first. And so whenever we talk about an individual with an eating disorder, it is an individual with anorexia nervosa
Got it.
or bulimia nervosa. It's never an anorexic or a bulimic. Those are old, archaic terms. And so we know better now. And so we always use person first language. And then the other thing related to that is that if a parent or an educator or anyone interacting with kids observes behaviors or has concerns, oftentimes they just don't know what to do with that.
Right.
And so I think it's appropriate to stick to observational data. So, what are the behaviors that you're picking up on that you might have a concern? And then, if that is kind of a foot in the door way of approaching a child, adolescent, or even a young adult about what your concerns are. So, instead of saying, to kid A, I've noticed I'm worried that you might have an eating disorder. That is really going to shut down the conversation. And if what led you to that concern is that you've noticed that they've thrown out their lunch in the cafeteria a couple of days a week, every week, to say, kid A, I've noticed that you've thrown out your lunch 3 days in a row this week. Can you tell me a little bit about what might be going on? And so, again, there's no implication, there's no accusation. You reduce any potential shame or guilt, and you're really approaching it from an observe and describe stance. I've observed this. Can you describe for me, or can you tell me what might be going on? Or is there anything that I can do to provide any support? So again, and that first pass may not be the ticket, but it could be a couple of passes in a similar kind of approach that might actually avail themselves to, be willing to talk about what may be going on.
In a society, in a culture that we're in right now, where there are so many people giving advice about eating and weight and exercise, what sort of resources should parents, teachers, and direct service providers be looking for? What are the hallmarks of the best evidence-based practices and programs and materials that they can bring to the kids in their lives?
That is a great question. And you're right. There is a ton of information out there, and it gets very weedy. It's very difficult to tease out what might be pop science versus what's evidence based. And so I'd like to share maybe 3 websites that are useful.
Please.
2 of the websites have healthcare professional facing information, as well as family and individual or patient facing materials. And then one is specifically for parents and parent support. So the 2 that have all the different types of resources would be National Center of Excellence for Eating Disorders, and that website is nceedus.org. The other one that has a similar type of information would be NEDA, which is National Eating Disorder Association, and their website is nationaleatingdisorders.org. What's wonderful about their website is they actually have an educator's toolkit, which I think would be terrific for a lot of your listeners. And if I remember correctly, it's been a little while since I've gone to the toolkit section. I think they might also have a coach's toolkit as well.
Oh, wonderful.
So there it goes through signs, symptoms, interventions, things to look out for, what to do, etc. I think those are really, really wonderful resources. And then the website that's fantastic for parents and parent support is a website called Feast, FEAST. Feast stands for Families Empowered and Supporting Treatment for Eating Disorders. And their website is feast, FEAST -ed.org. So Any information on any three of those sites is evidence-based, peer-reviewed,
Right.
and has been validated. And so we, all of the ones involved in these organizations, update the information regularly as well. So if there's new information to come out, if there's updated research, et cetera, we will update the website accordingly.
Well, Jean, I want to thank you so much. By the way, we'll put links to all those resources in the
Great.
description of this episode, and
Great.
we'll be adding to the toolkit over the course of this series. But Jean, I want to thank you so much for taking the time to talk to us. I know I learned a lot, but I also want to thank you for your work. What tremendous and valuable work. So thank you so much.
Well, thank you for having me. And if your listeners ever want any additional information, I'm happy to come back.
That was Jean Doak. For more information about Jean, including the links to the resources she cited, please visit talkingaboutkids.com. The Talking About Kids theme song is by the Senators. For more of their music, go to thesenatorsmusic.com. And remember, kids are young goats and young humans. And the difference is that young goats are easier to manage.